Today's training focuses on a rare but time-critical emergency you may encounter in your career, an amniotic fluid embolism, also known as an AFE, and maternal cardiac arrest. Maternal cardiac arrest is a unique and challenging medical emergency. Pregnancy changes physiology, it changes how we perform CPR, it changes how we think about airway management, it changes transport decisions, and it introduces a second patient whose survival is directly tied to our speed and accuracy. This video will inform you about an amniotic fluid embolism and teach you the best ways to prepare and perform for that rare and time-critical moment.
I want to start by thanking Orange County Fire Authority for inviting me to be here today and be a part of this training and to share my story. My name is Matthew Okula. I'm an engineer and a paramedic for the Los Angeles City Fire Department. And on March 29th, 2025, I tragically and unexpectedly watched my wife, Haley, pass away while giving birth to our son, Crew. Haley was a registered nurse in the emergency room at Los Alamitos Hospital, as well as a nurse educator for her business, our new grads. She loved teaching and she loved educating others. So Haley and I had a long struggle with infertility. Almost 2 years it took to finally get the news that we wanted, and we eventually had to turn to IVF. So when we found out that we were expecting, we were on top of the world. On March 26th, we went in for a scheduled induction. Haley was 41 weeks pregnant, and after 3 days of labor, we went with the doctor's advice of doing a C-section. Everything seemed to be going smooth during the C-section. They lifted Crew above the curtain. Haley saw him, had a big smile. I stepped aside and cut the umbilical cord, and it seemed textbook. I gave Haley a kiss and told her how proud I was, and I went to the room down the hallway with Crew, waiting for Haley to come back in. I remember being in the room with Crew and another nurse, and I had my back towards Crew because I wanted to wait for Haley to come in. It was a moment that we thought may never happen. When the door finally opened, rather than Haley coming in, it was a doctor with the worst news imaginable. He told me that Haley had gone into cardiac arrest and they were doing everything they could to revive her. I couldn't even describe the feeling that I had. I rushed out, and as soon as I saw a whole team working up Haley, my mind didn't know how to process it. I was in shock. I didn't know to stay with Haley to see if my son is doing okay. I decided to go with Haley to the ICU, and I stood bedside for over 4 hours until the hard reality finally began to settle in that she was not going to be coming back. And now I'm faced with these two realities, losing my wife and becoming a dad in the same moment. Later, I found out that Haley suffered a suspected amniotic fluid embolism, or an AFE, which is a rare but often fatal maternal complication where the fetal cells or amniotic fluid enters the mother's bloodstream. They have a severe anaphylactic reaction, which can cause cardiorespiratory arrest, and a severe clotting disorder known as DIC, which can lead to massive bleeding. And I'll be completely honest, I've been a firefighter and a medic for over a decade, and I've delivered numerous babies, and I've never heard of an amniotic fluid embolism before this. My wife, Haley, was a registered nurse and a nurse educator, and I have never heard her mention AFE before. So why am I here today? I'm here as a firefighter speaking to firefighters. We don't see this often, and I understand that it's easy to get complacent through training that we don't come across often. I'm guilty of it too. We check the box and move along in our day. But rare does not mean never, and it can happen on any shift, in any community, to anybody. These outcomes depend on early recognition, calm decision making, and rapid action. Your ability to recognize this early can give this family a different outcome. So my hope is that you take this to heart and carry it with you in the field.
They said we couldn't do it, but looks like we made it. Look how far we've come, my baby.
She went into cardiac arrest, and the doctors say it was from a very, very rare complication known as amniotic fluid embolism. She gave her life in the most noble way. She was able to see him for a split second, and I'm always going to remember that. She was the 1 in 40,000 that gets amniotic fluid embolism.
Hi, thank you so much for joining us. My name is Miranda Clausen. I am the executive director of the AFE Foundation, and I experienced an amniotic fluid embolism during the birth of my son back in 2008. And I am so glad to join you today and to follow Matt's incredible story. I got to learn of Matt shortly after Haley passed away. And when we were able to connect and talk to one another, and when I realized that he was a paramedic and that Haley was a nurse, it was very clear that we would collectively work together to make it our mission to raise awareness about AFE and prepare both those that are in hospitals and out of the hospital setting on what to do during these events. So my hope for today is just that you'll get a little bit more experience around what this rare occurrence is around amniotic fluid embolism, but also that you'll understand a little bit more about maternal cardiac arrest, the physiologic changes that happen to a pregnant patient, and also some suggestions of how you can manage maternal cardiac arrest should you find yourself in this situation. So I want to start with amniotic fluid embolism. It is definitely a mouthful and probably something that you've never heard. It's not in the What to Expect When Expecting book. In fact, most people in healthcare have actually never heard of it, or if they have, it's just a small paragraph of a small chapter of a small book around obstetric complications. It is a high acuity event, meaning that it is a birth complication that happens that's unpredictable, it's unpreventable, it's actually even in most cases untreatable. But it's considered a halo event where it's a high acuity and a very low occurrence. So thankfully, it doesn't happen commonly, but it is something that we need to be very ready for and have rapid recognition and an immediate response. It is life-threatening to both mom and baby, so that means that most often when this occurs, it will occur when the baby is still in utero. And so it's something that not only is it going to impact mom, but it will eventually impact baby if we don't deliver that baby quickly. It's referred to as an allergic-like reaction or an anaphylactic-like reaction. It's essentially what happens when the amniotic fluid that surrounds the baby enters the mom's circulatory system, which it does in most cases in birth. But in some of us, it has a very catastrophic immune response that shuts down the heart, the lungs, and it even interrupts the clotting cascade. So there's 3 hallmarks of AFE essentially that you need to know. One is the immediate signs that you typically see, which is going to be sudden hypoxia, sudden hypotension, And because of that, it's going to elevate the individual's heart rate. In addition to that, if they make it through a cardiorespiratory collapse, which could lead to cardiac arrest, they'll actually also suffer from pretty significant bleeding, or DIC. This is because both the clotting cascade is activated as well as the hemodynamic collapse when this fluid enters the circulatory system and initiates a cytokine storm. So how often does AFE occur? It actually, fortunately, is a rare event. It occurs 1 in 40,000 deliveries. And to put that into context, there's 4 million births in the US every year. And so roughly 100 to 150 women will experience an amniotic fluid embolism. These numbers are difficult to ascertain simply because AFE is very complex. There is no clinical diagnostic criteria around it. And so there's no tests. There's not a blood test for it. There's no imaging to test that this is what's actually happened. So getting those numbers can be very challenging. So we either get those numbers through discharge data, or we get those from vital statistics. So they're not great, but we believe that it occurs 1 in 40,000 or 150 women per year. The mortality rate on this has dropped pretty considerably over the last 20 years, largely due to incredible critical care interventions, ECMO, massive transfusion protocols that have come to place. But the mortality rate is still pretty high. It's somewhere between 20 and 40%. And again, that really depends on where this event occurs, how rapid the response is, and how significant the cytokine storm is that impacts the body. So we like to call it a spectrum disorder, where you can have a mild case and you can have a very extreme case. In terms of infant mortality, it does also impact the kiddos. It depends on when this event occurs. So if it occurs during the labor or it occurs before delivery, we see pretty significant rates of hypoxic injury to the infant, and mortality rate is roughly around 20%. What we see most profoundly is that 87% of these cases are going to experience a maternal cardiac arrest. It's pretty considerable when you think of that. 87% of all of these women are going to have a cardiac arrest at some point in their AFE spectrum or in their symptoms. In almost 40% of those cases, it's actually the first symptom. So when does AFE occur? It occurs most often in labor. And so how does that impact you as a paramedic? This could be in a birthing facility, it could be, or in a birthing center, it could be somebody who's birthing at home, but also for somebody who's laboring at home. When we live in congested areas, sometimes being able to get into the hospital and having a bed available isn't always the thing. And so many people actually stay at home when their waters break, or if they have other children and this isn't their first rodeo, they tend to stay home and stay comfortable until birth is imminent. Then they will actually go in. It does happen in rare instances where an amniocentesis is done, or a D&E, potentially an abortion, and these would happen in outpatient clinics, not in hospitals, so you may be responding to one of those events. It also happens immediately postpartum, so if somebody has had a home birth or a precipitous labor, or challenging if she's had delivered in your rig, it could happen in the postpartum period as well. So this is the most significant timing when you might encounter an AFE. I want to talk a little bit more about signs and symptoms, because when I think about you as a paramedic or as somebody who's responding, you often have to ask the bystanders that are nearby, or trying to ascertain from the patient what she may be feeling. And I just want you to take some time to look at these and recognize, because this may point you in a direction which will help you as you reach out to your delivering facility about how you want to communicate what's happening. This impending sense of doom is a prodromal and early symptom that is really strange. It's a strange phenomenon that we see in our community. It's very similar to when you hear when somebody's having a heart attack or a pulmonary embolism, but essentially it means that somebody's saying something like, "This doesn't feel right. Something's different. I can't explain it. I just feel like something bad is going to happen." Other early signs and symptoms outside of that is also going to be like an altered mental state. Now, you may not be able to witness that unless she becomes obtunded or she's not responding, but this is something, a good question to ask when you're arriving on scene is, how is she, what has she been doing? What has she been saying? Has she changed? Has she had a personality change? Because that can lead you in a couple different directions. But what I will say with altered mental status is that typically it is very high anxiety where a patient becomes restless. She begins to say that something's not right. Something feels strange. She feels like she can't breathe, or she becomes agitated as well. Fetal compromise may not be something that you see out there unless you're hearing this and you're picking up at a birth center, but fetal compromise is essentially when the baby's heart rate starts to drop. You could be called from a birth center that somebody needs to be transported to a facility because they have fetal compromise and they're not able to actually deliver that baby. Other signs and symptoms include hypotension, so a very significant drop in the MAP, very significant drop in blood pressure, an increased heart rate. Respiratory distress is a very hallmark sign of AFE, where people are verbally saying, I can't breathe. I feel like there's something wrong with my chest. I'm having a hard time catching my breath. Some of these signs, like nausea and vomiting, may be a normal physiologic sign of birth, but in this, it's very profound where someone will express they think they're going to be sick. Leading right up to the cardiac arrest, we often see seizure-like activity. It could look like a tonic-clonic seizure, and it can certainly mimic what we see as a hypertensive crisis or hypertensive seizure. But in these cases, it's really just a hypoxic event that leading to the cardiac arrest. And as I shared, 40% of these patients, their first sign or symptom could be a sudden cardiac arrest. I think this is an interesting topic about what actually is this and how did we come to know about AFE. Ironically, it was found 100 years ago. So in 1926, a woman had passed away during birth, and the medical examiner examined her body and found that there was fetal cells and fetal debris found in her lungs and throughout her vasculature of her body. And so while we know about air embolisms and pulmonary embolisms and blood clots, they had never seen something like this before. They had never seen fetal cells in the circulatory system of a mother who had died. And so they came up with this term, amniotic fluid embolism, for the embolic nature of the amniotic cells entering the circulatory system. Now, in 1926, we didn't have great CPR. We didn't have a lot of great things. And so obviously anybody who had one of these events was definitely going to pass away. But over the years, we've gotten better with CPR and critical care and understanding cardiovascular collapse, that women actually were able to survive the initial event. And so what they found was that many years later, that women were able to survive the initial event, but then they would go on to have this very catastrophic bleed, or DIC. And so that didn't explain that they believed that this embolic event basically got into the lungs and caused the lungs to be obstructed and not work. Now it confused that ideology, where now they realized, no, actually, even if you put an entire liter of amniotic fluid into a woman's lungs, that it wouldn't fully obstruct the alveolar space. So they recognized that this was no longer an obstetric issue. They recognized this was no longer an obstruction issue, but rather a immune response. So like a severe allergic response to this fetal debris. So what's actually happening? I know this chart could look very overwhelming. It's got a lot of boxes and it's probably very small. I know it makes my head spin sometimes too. But I think this is really important to lay out and to show you really what's happening internally and what you're able to visualize for these patients. So we know that it's when the amniotic fluid enters the circulatory system and it causes this activation of various endogenous mediators. But what you'll notice on the bottom is the signs and symptoms that you will typically see. So that's where we get that acute and sudden hypoxia, where she starts to desat suddenly. We also know that what's happening in this case is that as she has hypoxia and hypotension, that it leads to transient pulmonary hypertension, which then puts pressure on the right ventricle, which then unfortunately challenges the left ventricle, which leads to a cardiac arrest. That's the very tip of the iceberg. And what you don't realize is what's happening underneath. And what's happening underneath is the activation of the clotting cascade. This is incredibly complex. Essentially, when DIC is activated, all the platelets aggregate together. And so you create many clots in the body. And then the body does, and the blood cells do what they do best, which is to break down those clots. And when they break down those clots, it creates little tiny ninja stars called fibrin split products. It's a process called fibrinolysis. It's very complex, and we don't have to get into that, other than to say that in addition to the cardiorespiratory collapse, you now have this very confused system where the blood is clotting and bleeding at the same time. And that can be incredibly challenging because it's not something that you see right away. It's typically something that you see anywhere from 20 minutes to 30 minutes later after this event occurs. So I know I've talked a lot about amniotic fluid embolism in general, and even gotten into the nitty-gritty of a little bit, but I also want to take a moment to really focus on what maternal cardiac arrest means for you as you are out in the rigs or as you're scooping up these patients. What does that look like? What do we need to know? What's different about a maternal cardiac arrest than a normal individual that suffers from a cardiac arrest? So in terms of how often or how commonly this occurs, they say it's 1 in 20,000, so twofold of what you would see for an AFE. 73% of maternal cardiac arrests are going to actually happen in the home, so you're going to be going to residences in order to pick up these patients. A small percentage will be, again, from those who have precipitous labor outside of the home in a car, who've maybe been involved in a car accident. There's a number of other reasons, but typically these events occur in home. The most common causes for a cardiac arrest for pregnant patients is going to be a postpartum hemorrhage that can happen either before, during, or after birth, or an amniotic fluid embolism. I know we've seen many cases called in that come in via EMS that have begun at home. The survival rate for these events, as you would imagine, is quite low. It's 16%. And a lot of that depends on, this is a national average and not necessarily something specific to Orange County, but you can see that it's low for a variety of reasons, and it really depends on the response. The occurrence of this has increased significantly since 1990. We know that there are definitely more out-of-hospital births than there have been in the past, which means that you may be responding to more of these calls. I think the greatest challenge, and we saw that number with the 16%, is just how quickly do we recognize that a patient is down or that a person is down, and that we need to act quickly and respond as fast as we can. So that number really reflects delays or absence of bystander. We just had a case very recently of a woman who was found down in her bathroom with 2 7-year-old twins at home who did not realize that their mom was sick or ill or needed attention. It took her some time to inform a neighbor and for that neighbor to come over and call 911. So as we would imagine, cases like that can be pretty tragic and very difficult. But we know there's other things that impact that 16%. It's EMS response time, how quickly. Fortunately, here in Orange County, you guys get to, your response times are excellent. There is definitely limited training around obstetric emergencies and maternal cardiac arrests. And there are some suggestions and modifications that you could consider when you're actually treating and responding to a patient who's pregnant, especially a patient who's over 20 weeks pregnant. There's also sometimes a lack of physician response on the receiving hospital. I don't think that's an issue here, but that's something that will definitely impact that national average, which is, are hospitals prepared for an obstetric emergency when they receive them in the emergency department? So let's just touch on what those physiologic changes are that happen in pregnancy. I know as an individual who's actually given birth, I was stunned to realize how many things outside of our bellies getting bigger and outside of our crazy cravings, and maybe that we get a little bit more stuffy. There's actually quite a bit of changes that happen physiologically in a pregnant patient. So I first want to just kind of go over just the structural and functional changes of the heart in general. I think this is always fascinating. I heard this somewhere, like, oh, our heart's enlarged and we have way more blood than we've ever had. But I want to put some data behind that. So yes, a pregnant patient's resting heart rate will be elevated. Our blood volume does change, actually. We have increased red blood cells and plasma. That helps with the anemia, as well as the impending sense of delivery that you need to have a greater increase of red blood cells. The cardiac output also changes because the heart needs to adjust to that greater volume. Our cardiac output actually does go up. In addition to that, our systemic vascular resistance goes down as a result of these many changes. So you can have an enlarged left ventricle to manage and to be pumping out to increase circulation. We've got another organ. We've got a placenta that we're perfusing, and we've got an infant that we're also perfusing, sometimes 2 or 3. So how do these structural and physiologic changes impact what you need to know about this patient? Patients and women who are pregnant, especially beyond 20 weeks, have this gravid uterus. So as the infant continues to grow, it definitely puts pressure, and this is why we say for women not to sleep on their backs when they're pregnant, is because after 20 weeks, the compression on that inferior vena cava is definitely impacting blood flow that's impacting for her as well as perfusing the baby. So the cardiovascular effects actually do make a difference in terms of how much oxygenation is actually occurring. So when you have a cardiac arrest and they're already in a supine position, we want to do everything we can to try and release that aortal cable compression. There's also other anatomical changes. I just want to address them and just let you know that we can definitely have physiologic changes for airway. We know that pregnant patients have more narrowed airways. That comes as a result of various hormonal impacts. Also, in addition to that, we have changes in the diaphragm. We have changes in their elastin and relaxin in terms of their rib cage and expansion of their lungs. So there's a lot of changes that will impact how good chest compressions and how quickly these patients can actually recover from a cardiac arrest. And I just wanted to make sure that while we don't have to go into great detail, it is important to know that beyond just her cravings and her big belly and maybe her swollen feet, there's some pretty significant changes that do impact how we respond and how the body responds to these types of events. So what do the pulmonary changes that I shared with the diaphragm and with the vascular resistance, how does that change the pulmonary effects? Again, it decreases the lungs' functional residual capacity to fill back up. The diaphragm elevation limits the lung expansion. We have a decrease of oxygen consumption back to the fetus for their metabolic needs. And we have a much faster onset of hypoxemia. So it's really no surprise that when we have a hypoxic event, that these patients go down very quickly, and their ability to oxygenate and to get oxygen to their brains and to their hearts is very compromised. So all in all, what does that mean for you? Now, we talk a lot about how we always do ACLS in these circumstances, and that is absolutely no different. But I do want to share that there could be some potential modifications or things that you could consider when you're treating a maternal cardiac arrest out in a rig. So we know that we do high quality CPR and ACLS standards. I know you guys do that so well, where we do fast compressions, deep compressions, and allow for full recoil. But we also want to consider what's happening with this inferior vena cava and this gravid uterus. So I know that many times we do a lateral tilt, which is still something that you could do. It may interrupt your ability to do chest compression. So there's another consideration. And so perhaps you can try a manual displacement of the uterus. So you would do a left uterine manual displacement. So you can either actually push the belly off or pull the belly to you depending on where you are. We know that early airway management is absolutely critical for these patients. As I just showed you, there's a lot of physiologic changes in the heart and in the lungs. So we want to make sure that we are getting early access to the airway. And these airways can be very challenging, especially the further along they are in their pregnancy. And then also, if you are placing lines in the rig, should consider doing, making sure that those placements are done up above the diaphragm. So large bore IVs will be up above the diaphragm. So these are just some considerations when you're faced with a maternal arrest in the rig. Here's just a quick example of how you can do that left uterine displacement. So again, you can either push with one hand or you can pull with two hands. And again, if you have a Lucas device or there's two of you, you can take turns with doing compressions and then doing this uterine displacement. Ultimately, I know that we talked about something incredibly rare and something that definitely hits home with Matt's story. So key takeaways: what do you need to know about amniotic fluid embolism and maternal cardiac arrest? While these occurrences are low, we've explained just how catastrophic these events can be. Our organization actually has a hotline where hospitals can call in and ask questions about how to treat these patients, because the treatment, once they do get to the hospital, is aggressive and it's complex, and these cases are catastrophic in most situations. But what I really want to drive home is the importance that you play in the rigs if you are picking up one of these patients or you do find yourself with a maternal cardiac arrest, is just to understand that there are physiologic changes that is going to make it difficult for this patient. That your rapid recognition and rapidly getting that patient from their home to the hospital. I know in Orange County, you guys have amazing response times and very short trips to the hospital, and that is such a win for our pregnant population here in Orange County. I definitely think that how you communicate with the receiving hospital will be so important. Asking those early questions with any of the bystander or their spouse or their family members will certainly help prepare the team that's going to be receiving this patient. We definitely want to make sure that we have a quick base contact for any OB receiving that has an OR. And certainly in Matt's case, and in many cases, we know that patients who are able to be placed on ECMO have very good responses. So it's another consideration is as you have trauma centers is to recognize if you have a pregnant patient, can you get them to an ECMO capable center? And just always remember that you could have 2 or 3 patients, and the resuscitation of mom absolutely helps baby, but the faster we get that baby delivered, the better chance that mom has at survival. I thank you for your time, attention. I thank you for your being first responders. Truly, on behalf of myself, our organization, and the patients and populations you serve, I thank you so much for your time and dedication.